Hi, welcome everyone. It is May 5th. Oops, Cinco de Mayo. This is House Healthcare, and we are starting off this afternoon with S-193, which is obviously, if you recall, a bill that we don't actually have possession of, but we've been asked to make recommendations on for the forensic facility. And I will say, I am kind of going to turn things over to facilitate to Representative Becko. She's done a lot of great work on this and working with Legislative Council and various stakeholders and has some things to present. So take it away, Daisy.
Hopefully with the help of Ms. Glenn, who I just met with to share a document that I've emailed out to the committee. Tasha's bringing us hard copies in a minute, but what I've done is we sat in on House Human Services on Friday afternoon. They were discussing the language that House Corrections and Institutions has. I think it's in their committee draft 2.1, and took into consideration the direction that Human Services was moving, but also tried to create a framework for this committee to speak to the things that would really be within our jurisdiction should there be people with mental illnesses in a forensic facility. So in the document that I sent around, you'll see I put some recommendations, and these recommendations are drawn from best practices in other states that do this. They're drawn from testimony by Vermont Care Partners and others. And the goal is to, again, give us a framework to sort of react and weigh in on this. And then Katie, during our meeting at noon, is lifting up some of these points and saying, well, this one could actually go in the existing language potentially, or this one wouldn't be relevant until further in the process. So I think maybe just reviewing it and maybe with Katie's guidance, we can lift up some things and see if there's alignment.
Can you just tell me, you said you sent out language, just remind us what time and the timestamp so we can find it.
About 5 minutes ago.
I saw that. I was looking through my email and then I refreshed and it appeared at the top.
Okay, and we'll have
right, thank
Tasha,
you.
when Tasha gets a minute, we'll have Tasha post. She's gonna hand out hard copies to us.
So these are recommendations that you've compiled that for us to review based on our
And you've
conversation.
reviewed them already.
Yeah, and based on our discussion and your research.
Yes,
Okay.
and testimony from people
Thank
in
you.
Civil health and welfare. And then the conversation that's going on in human services, corrections and institutions, and I haven't listened in on judiciary.
Okay, so who has jurisdiction over this?
We, on this document that you're looking at, I'm showing us where we have jurisdiction over this.
So the jurisdiction, the official jurisdiction of this bill is in House Judiciary right now.
And all we're doing is showing our concerns and suggestions.
Yes, that's what we're doing. And we're sharing our concerns and suggestions with House Judiciary and House Corrections and Institutions. And I believe Corrections and Institutions is not going to take, at this point, they're not going to take possession of the bill, but they're working on stuff.
I'm not sure at this point. Yeah, I've heard.
I heard it might go there. Yeah, so I don't know.
Leslie, do you want to go ahead?
Just a question, looking it over quickly, and I see the clinical model required discharge planning and transition. I wonder where the victim fits into this. We did have some testimony from victims.
I suggest we start at the top.
Yeah, let's start at the top.
Do you want us kind of enter the points, or would you rather I?
Either way is fine. I can go through them. Recognizing they didn't come from me. And then I guess what I'm thinking is as we go through each one, I'm just gonna kind of take notes about where it might be integrated, and then I'll sort of have marching orders by the time I walk out the door this afternoon. Hopefully. Okay, so this is the governance and ownership. The first bullet is require the forensic facility to be established, licensed, operated, and clinically governed by DMH or a DMH contracted provider. This is one of the tricky ones. I'll say this several times because we know that there might be multiple departments with jurisdiction. And so figuring out how that cooperation will work. Will there be sort of hybrid operation of a forensic facility? How will it be licensed? One thing Representative Rebecca and I just talked about is how Human Services was concerned with the Corrections and Institutions proposed amendment of licensing the forensic facility as a therapeutic community residence, a TCR, because some aspects of the TCR are not applicable to the forensic facility. And the conversation we had 20 minutes ago was that this could be an appropriate addition to the forensic facility plan report that's coming back, specifically asking the administration to look at the TCR rules and identifying which aspects of the TCR rules would have to be waived in order to license the facility as a TCR. So that is something I could potentially add.
And this will be in the feasibility study?
Yeah.
Okay.
And if you remember,
TCR.
I sent around on Friday, I sent around the therapeutic community residence licensing requirements and guidelines. So you all have those and you can see in the body of the email, I just cut and pasted kind of the top line of it, and you'll see that it, I think some of what Brian was noting in his vision for caring for this population in terms of being community-based and least restrictive setting. It speaks to that there are definitely things that wouldn't allow this facility to be a TCR. So I think that was a good recommendation, Katie's idea, to have the feasibility study look at what would need to be adjusted from the TCR licensing to make this carry some of those components forward, but not obviously all of them. Right.
Yeah, it's just related to that. So in statute, there's a definition for there's definition and criteria for a TCR, therapeutic community residence.
I don't know what is in statute. I know that TCRs themselves have rules where it's defined and all of the operational specifications are there. I'll look right now and see what we have in statute for TCRs.
Before you look further, let me ask another related question, because then
Okay.
we can fold it out. Which is I might get the term wrong. This is in statute, I believe it's called a secure recovery residence.
Secure residential recovery facility.
Thank you, yeah. Is that a TCR?
I believe it is licensed as a TCR. Do we have?
Yeah.
Yeah.
Because that's what I envision for our forensic, if we have a forensic, something like River Valley, so I'm just putting that out there, thank you.
That's another question.
Community residence didn't come up in my word search, but sometimes they're finicky. Anyway, first blush, I'm not seeing it in statute.
So the current proposal from corrections and institutions is that it be licensed, operated, governed by AHS, correct? AHS, but not DOC. What about the scale in here?
Human service, I think I have to step far back. So the proposal you got from Senate had DOC in charge of the facility. House Judiciary changed their draft to say Secretary of Human Services. Since then, this committee and Human Services had both sort of had conversations that the departments of jurisdiction should, be in charge of their own, the folks that they have the most expertise on. But that said, as I'm sure you know, Human Services is not inclined to have individuals within Dale's custody in the forensic facility, and they are looking at possibly expanding current Act 248 population to see if they could address some of the individuals that are currently picked up in this proposal that aren't currently under Act 248, like people with dementia or people with TBI.
Okay, if however, somebody within their population is at risk of safety to themselves or others, where would they be held?
Say that again, I'm sorry.
So
Somebody,
are they are they thinking of expanding 248 to include that someone could be in a forensic facility?
In the custody of them.
I don't think they envision anyone in Dale's custody being in the forensic facility. I interpreted it as they were going to expand Act 248 residential placements. That's what they're interested in. I don't think they're necessarily thinking that the language will be changed this year to do that, but that it's something they want to ask the administration for more information about as to if that is appropriate.
What about somebody with co-occurring?
I think it depends what their predominant diagnosis is.
Um, Okay.
Leslie had a question, I think.
I don't know if this is the time you might talk about it. When I read the stuff you sent out on Friday, about therapeutic community residents, I wasn't sure, how it applied to people with, violent potential. And that's what worries me about, and I need to understand how that intersects. The potential for violence is worrisome to me in the community, and how do we think about that?
I think that's why we need a feasibility study.
Okay.
Because the TCR does not apply to that population. Nothing in our state does right now.
Okay, so so what you sent doesn't really apply to that population?
No.
Okay, so that was what confused me.
That's a proposal. That was the Human Services proposal, is that it be licensed as a TCR.
That the forensic facility get licensed as a TCR. Right. So it uses those
Parameters.
principles, let's say, whatever, but then takes in that potential for violence. I mean, and you know, this issue with dementia and TBI, I don't know enough. I mean, have really basically no knowledge about that kind of population.
Well, they're not our jurisdiction anyway, so we don't have to weigh in on that.
Truly, but if we say they could be in the community, and there's a potential for violence, I think that that's worrisome to me. And maybe we just say we have no voice, and I get that, but that's pretty worrisome to me.
Yeah, I mean, correct me if I'm wrong, Katie, but I think we should focus on the mental health population. And then hopefully as the process of coordinating with the other committees evolves, we'll, work through Ledge Council and the chairs to find some language where we all can agree on what the path is. And then what we don't know, the people who are actually the experts on caring for these folks will figure it out through the feasibility process, study process.
Okay, so just so I understand, I'm sorry, but you're suggesting that we just work with the feasibility study right now, and that's what we want to have come out of this conversation?
No, I think that we don't have to resolve right now, like what the pathway is for every population. I think we should focus on what we want our recommendations to be for the folks who are in there with a primary diagnosis of a mental illness. And look at these recommendations, see whether or not we want to take them forward, and Katie can advise us on what the best means and time for taking them forward is, or whether or not we want to.
Thank you.
Can I just correct myself quickly? The therapeutic community residence definition is at 33 VSA 7102, if anyone wants to look at that. And then more specifications about the license type is in 7103, 7105. So that's where you'll find it in Title 33.
Okay, let's move on to the second bullet.
Limit DOC involvement to external security only if necessary. I think that the proposals that you've seen from House Corrections and institutions sort of says that as well. So I don't know that you need any additional language to do that. Governance models similar to mental health agency oversight models used in other states. So I think you could ask as part of the plan to have more information about models for competency restoration or forensic facilities in other states. It sounds like also there are a lot of ideas of how you want it to function, and maybe that would be a preliminary step and you're maybe past that step at this point. I don't know. But if you wanted to ask for more information about that, potentially the feasibility plan would be the place to ask it. The plan, at least as how Corrections and Institutions envisions it, is not a report back on like, how is this, give us more information so we can make up our mind. It's more, we've made up our mind, this is what we want, now how do we get from point A to point B? So it's assuming that we're sort of along in the process and a decision has been made to have a forensic facility. These are the elements we want in the forensic facility now. How do we do it? If that's helpful.
Very,
Number 2 is the facility purpose. So defined as a secure treatment facility, not a correctional institution. I might just read all of these together and then talk about them. Clarify the placement for competency restoration, evaluation, stabilization, and treatment, not for punishment or detention. Ensure statutory language distinguishes this facility from a correctional facility. So I think this could maybe go somewhere right in the language itself. I don't know that would be part of the feasibility study, but if you want language that this placement is competency restoration, evaluation, stabilization, and treatment, we could use those words, maybe in the definition, maybe somewhere else. But I
They're
could,
already in there too.
I think a variation of this, I don't know. Do you want me to look into that or leave it?
What else is in there currently?
Well, you have that section. Hold on. You have section 4B that has a list of different clinical aspects. Right now, let's see, right now you have in the definition section that it provides for the secure evaluation, treatment, and care. And you're looking at language, competency restoration, evaluation, stabilization, and treatment. And then you say it again, secure evaluation, treatment, and care. So that could be replaced.
Sort of worry about losing care.
Add it.
I mean, what if somebody is not actively? What if somebody's not actively engaged in competency restoration or evaluation or stabilization or treatment? What if they're just a danger to the public?
And they don't have a clinical reason to be there.
Yet to be determined. Well, I mean, it kind of goes back to our, sort of our discussion that we had around what's happening. Some of the designated agencies and the designation change, CRT designation change. In that if you're not actively working towards restoration or working on treatment, what if you've just gotten to the point where you are stable where you are and yet you still pose a danger, which it seems to me like the word care encompasses.
can you tell me what page you're on, sir?
It's on page 2, line, well, I don't know the line numbers on this draft, but it's section Z3. I'm looking at the language that Katie gave us last week. Yeah, it's the correctional institutions.
It's not 3.1. Is it?
No, well, there's language there too that I just read from. But there was a document from Corrections and Institutions that I gave you last week. You don't have a hard copy of.
I'm just putting it out there for discussion, so.
It would be easy enough to add with your list or with a list on this document if you wanted it to say everything.
Fran, what do you think?
I'm thinking about what I'm wondering, I guess, and I guess this is a study, but I'm wondering what are the evidence-based practices for competency restoration, what's considered the best? I'm also wondering, I mean, you asked, so this is what was kind of going on in my head is like, is there a place for looking at emerging treatments? For example, imagine if a person when they're asked to do competency restoration, there's like a menu and they get to choose what they want to do to restore their competency versus like just one size fits all, you know? Because that menu could include emerging treatments like neurofeedback, for example, which I think should be offered in all correctional facilities right now because of its potential to address criminogenic behavior. But like there's emerging treatments. So, I mean, what would be interesting is for this feasibility study to say, here's not only the infrastructure, but here's all the different programming options and what they cost. And here's how and maybe some of this programming can be used for competency restoration and more. That's the other thing is like if we're going to invest all this resources in 6 beds to provide a very specific niche of treatment for a very specific population, is it possible that investment might serve others in the system of care, whether they be like people who need secure, like what you were just saying, what about people who are just unsafe, you know, like to help them become safe again,
Yeah, but
wherever they are.
I'm
you
not
know?
really talking about the competency restoration, because if you're engaged in competency restoration, that is inclusive in here. And once you've had your competency restored, you then move back into the criminal justice system and face,
Yeah,
yeah, so I'm not worried about that. Because as long as it takes to restore competency, they will be there. There will be placement for them. And if they're being evaluated, there's placement for them. And if they're trying to be stabilization, there's placement for them. And if they're actively receiving treatment, there's a place for them. I'm worried about once all of that has been determined to happen and, you know, they're not actively receiving treatment. Maybe I'm getting too, I think it's.
I brought this up the other day.
I think of treatment as like trying to get to something.
Yeah.
What if you get to something and you are now stabilized and yet you still remain a danger to
yeah.
the public?
This is what I was saying the
That's
other
what
day, is like, I'm
thinking about.
concerned about the lack of aftercare, because we restore someone's competency, but then if we throw them back into a cell with another person who has schizophrenia, like, which we did, and one of them killed the other one in Vermont, this was all in the news, like, they put 2 people with active schizophrenia in a cell, and they fought, and one of them killed the other, so we stabilize a person, but if we just throw them back in a cell with another person who's not stable,
I can't,
so like,
I can't stop that process. That's, the competency restoration is a criminal process. And it's a legal process. It's not.
but it is treatment, and what I'm saying is what the treatment we're offering in the correction system isn't gonna support maintenance of competency. That is, I feel like, our thing, like, that if we're not providing healthcare in our correctional facilities that promotes recovery, then what are we doing in our correctional facilities? And so if we spend all this money to recover someone, to have them stand trial, but then we throw them back into a place where they're not getting healthcare, you see what I'm saying? Then we're not keeping them safe.
And I
Safe, yeah.
totally see your
Yeah.
point. But we're not dealing with the correction system. I mean, that's why we have recommended that this not be under the Department of Corrections. So I'm just trying to think about the aspect of, if we are going to have a forensic facility, what is it going to be used for? Who is going to be there? And are we ensuring that any language that we have allows the correct ability to protect the public with those individuals that are there? So I can't deal with with corrections. And I get all your points.
Can we go through, because everything I think will be addressed. We have a clinical model section coming up. There's something about patient rights. There's also time limits and transition to appropriate levels of care. So what happens when folks are no longer in need of treatment? And I think those pieces are under different sections.
Okay.
So now, ask an absurd question. Can people go in and out of competency?
Yes.
So that's another thing that worries me. Yes, today you're competent, but maybe not next week. And I don't understand how to deal with that.
Let's go through
Okay.
the sections, please, because we only
I
have
see your
Katie for
point,
another
too.
25 minutes.
Okay.
I want everyone to kind of at least glance
Yeah.
at the headings so you know where we're going.
The clinical model require individual evidence-informed competency restoration plans. I think you could put that in section 4B, but I think you might also want to think about what's being done to people who aren't there for competency restoration. What about people who are not guilty by reason of insanity? So, maybe individualized, clinical plans, for lack of a better word. But some type of individualized.
You're making sure that we're capturing both populations.
Okay. Include psychiatric care, bed management, legal skills, education, rehabilitation, and trauma-informed care. I'm assuming, is that for everyone? Is that part of competency restoration?
That's part of competency restoration, like the court procedures, education, and legal skills.
Okay, I think we can put that into 4B. Require discharge planning and transition support to begin at admission. I don't know if this is the right place to talk about it. No, you have it somewhere else. So to me, this bullet and the last bullet in 4 kind of go together. Establish a continuum of outpatient, community-based, inpatient, and secure treatment options. So I think what those are both getting at is that what happens to somebody after they leave a forensic facility, and definitely heard in human services, and I'm hearing it a little bit here, that there is an interest in seeing type of like a plan in which a person is followed after they leave a correctional facility and have services for that person that are well, in human services, they said residential, clinical, and case management services to sort of monitor and ensure that person has what they need to be successful in the community. So if that sounds right and you want to see that, I could put that as part of the forensic plan, not the forensic plan, the forensic facility plan, feasibility plan. That would be something that they would have to, the administration would have to report back what is the plan for after somebody leaves. And here are the elements you'd want to see. What would this look like?
Yeah, and what is the where is this facility on this continuum of when folks are not guilty by reason of insanity, where do they go? Do they go to River Valley? You know, and I think that's the intent of those bullets, is making sure that everyone has a plan. People aren't just going to reside here forever. And that there's a plan first for restoring competency if that is their issue. And second, that once it's restored, where is the next appropriate place that's the least restrictive place, but also best for public safety if they're a person that's danger to the public?
Okay, put that in the feasibility plan.
Dave has a question.
I see, and I agree that can safely meet the individual's needs, but how about the community? I think there's some people, a lot of people actually are concerned about putting them in a community based, and they still are a danger potentially to the public. Is that in the language of the actual bill, or?
Yeah, and I mean, I think my way of approaching these recommendations is that we're looking at folks with mental illnesses. We're not looking at the overall public safety. Public safety is in judicial committee.
Right.
And I mean, obviously, I care about the safety of the community, but I feel like it's harder for us to determine that with the expertise that's in our jurisdiction.
Well, hopefully with the the level of care and the follow-up, hopefully that will prevent it.
Exactly.
Can I comment on that?
Yeah, can I just say something? First of all, Brian, I apologize. I think I might have just connected the dots that I wasn't connecting.
And what I was
So you're-
saying,
Yeah, so you're talking about competency has been restored and yet the legal process has not come to a conclusion.
that's right.
You're talking about the interim.
Yeah.
I thought you meant forever and ever and ever. Even
Like
after,
sentencing versus
after
detaining.
sentencing.
Yeah.
That's it. So again, I apologize.
Yeah.
I don't think I
Although
was.
I will
connecting the
say that I
dots.
feel like, I feel like when
Sorry
someone's
about that.
sentenced, we should be wrapping them in every possible service to rehabilitate them, including evidence-based practices for changing criminogenic behavior,
Right.
instead of putting them in a setting that drives criminogenic behavior.
I agree.
Yeah.
And I guess I thought that you were just talking about that piece. So-
Okay, well, thanks for,
So, yeah. I'm-
for
I'm
reflecting
like,
on it
oh,
further.
well, no, I was like, oh, no, that's what he was talking about.
Yeah.
So I don't want to go back, but, should it be for competency restoration and maintaining restoration?
Persons awaiting trial.
Yeah.
I don't exactly know where to put that yet, if it should be in statute or in the feasibility plan, but I'll write it down and figure out a home for it as I go.
Can I throw another
Can
phrase
you
out
tell me
there?
where you're at in this?
Well, that the placement is for competency restoration, but also that the placement is for maintaining competency throughout the legal process.
Like the feasibility study would be looking
Yeah.
at that. Can I throw out one other phrase, and if it gets shot down, so be it?
Actually,
So you said maintaining competency, and I would add and promoting recovery. And the reason I say that is because they go hand in hand like that, and I just think we should be recovery focused in general, but that if people don't want to complicate it, but I don't think it complicates it that much to tie them together.
Leslie.
Sorry. Um, I understand that you're thinking that public safety is not in our jurisdiction, but I would feel more comfortable if we would connect something that included in the plan considering public safety, or at least something that acknowledges that we're aware that we need, that's part of our brief as well. That would be important to me.
Where do you suggest putting something? Do you want to get through and see if?
Yeah, I mean, I would like to leave that up to Katie to,
Yeah.
think about where it would land, but I just think I really care about that.
Maybe we should I'm not in charge, but I'm noticing that we keep getting stuck. Maybe we should really try to hold questions till we get through all Daisy's stuff. It might save time.
Fine.
I'll personally try to do that. I've been trying to be quiet, so.
Okay, so 4, we kind of skipped over the first 2 bullets, so require DMH-led clinical review for admission and require documented clinical findings that no less restrictive alternative can safely be met on the individual's needs. So this is sort of looking at the court process. I think I will double check the work that House Judiciary is doing, and maybe we can integrate something about least restrictive setting.
That protects public safety, or, I mean, I'm sorry, but it's just least restricted setting.
That's already part of the work that House Judiciary is
I get
doing.
it,
That's
but I
part of
think it
the
should be
standard
articulated.
Spokane. Okay, section 5, patient rights, ombudsman oversight. Apply Vermont's mental health patient rights protections rather than correctional disciplinary frameworks. The conversation we had around that is that while there is something very structured around individuals with mental health, I don't know that we have something that's built out as much around substance use disorder. We do to some degree for individuals with intellectual disability. I'm not sure about dementia or TBI. I don't know if we have these kinds of protections built out in statute as much. I know your focus is on mental illness, and I'm just trying to think of the big picture of how we would ensure these protections for the whole population that would be at the forensic facility. So I'm kind of flagging this for more thought. Ensure access to counsel, grievance procedures, advocacy, and interpreters. The council is covered in the work of House Judiciary. But, access to interpreters and grievance procedures with the processes at the forensic facility could be built into section 4B. Require independent oversight, including review by mental health care ombudsman. That's easy enough to add to the jurisdiction of the mental health care ombudsman if you would like to see that. I missed that.
It's like the healthcare advocate.
Yeah.
It's just a different word.
And our mental health ombudsman testified on this, remember he testified on Zoom, Jack McCullough.
Oh, he's not the mental health care ombudsman. No, it's Disability Rights Vermont is the designated ombudsman. It's a federal designation.
Oh, okay.
So that office, for example, gets, I think they get the reports of seclusion and restraint. Is that right? I'm looking, yes, I'm getting nods. So a slightly different office, but I can add that to their statute. Staffing standards require staffing to meet clinical needs and best practices for forensic psychiatrists, psychologists, nurses, social workers, and peer support specialists. So we already have language in 4B about staffing. So do you want to list that these are the types of people who will staff the forensic facility? I'm not quite sure what the goal is here, that they meet best practices. Let me see what we have for 4B.
My goal was to recommend that in contemplating the design of the facility, the group, or the feasibility study group would consider these best practices around staffing with regard to these license types for folks with mental illnesses.
So right now what we have in the bill is that the forensic facility shall implement staff qualifications, licensure, training, and supervision requirements that are sufficient to ensure that persons transferred to the forensic facility have access to clinically appropriate care, treatment, services, and supports consistent with individual needs and with applicable professional standards. Does that meet that? Is that what you're,
I want to be more specific.
okay, how so?
Can we get the feasibility study? I don't know. I just feel like if we're going to look at different types of folks that are in there, I feel like it should become a smorgasbord, and like maybe we need to look a little more closely. Like peers are supposed to be provided at every level of care in our mental health continuum. Is this on that level, on the continuum? I don't know. I feel like we need to kind of have a deeper dive into that aspect of staffing, for example.
So you want the feasibility plan to address the types of professionals that will be working in the forensic facility.
Yeah. What are best practices for staffing?
Can we not prescribe certain
Job description.
job descriptions? I mean, right now I'm looking at forensic psychiatrist. What if you're a psychiatrist but not a forensic psychiatrist? Can you not work in there?
Well, that's why we're asking feasibility
Yeah.
study to look
Okay,
at.
that's what I'm saying is, can you read the feasibility study to figure out what the, and not prescribe?
What the multidisciplinary
Yeah.
team should be.
Yes.
Okay.
Thanks.
I think it's too specific.
Yeah. It would be ironic if they came back and said, just correctional officers. Just kidding. Sorry. So heavy.
So then you have required 24/7 clinical coverage, and in subdivision 6 of B, to ensure a registered licensed nurse or a physician is available to provide care to transferred persons 24 hours a day, 7 days a week. So does the bullet point on this draft, does the language in the draft get you what you want? And if not, how can we change it? So this says is available to provide care. So that is fairly loose language. That doesn't mean that somebody is on the premise of the forensic facility to provide that care. That could look like telehealth. That could look like somebody's on call. Maybe that is your intent. or maybe it's not. Does it have to be a nurse or a physician? So I guess I'm looking to see what your policy preference is on that.
Right.
I mean, my preference would be for it to align with the evidence-based practices for competency restoration. And since I don't know what those are, I feel like what the feasibility study should come back and say, here's the recommended multidisciplinary team and staffing strategies that, and maybe we ask for a few, maybe we say, don't just come with one so that we're like cornered in, but like, what are some options? So, I don't know. I'm trying to have us stay open-minded and not box us in too much to want something. Cause I feel like we were given a very specific proposal and it would be good to have more of choice, but in terms of policy decision, if we hear that there doesn't need to be in the therapy, I'm just gonna use this as an example, in a therapeutic community residence, there needs to be like an on-call physician 24/7, but they don't have to be on site, then I'm okay with that, But if we hear like in this kind of facility, you need an ophthalmologist on call at all times, then I would want it, but sorry, too soon. Yeah. I was trying to pick a random example and it wasn't random. But you know what I'm saying? I'll say a surgeon on, but I don't think we're gonna need a surgeon on site, for a forensic facility because they could take them to the emergency room. Anyway.
If we're requiring that staffing meets clinical needs and best practices, and then we're just requiring 24/7 clinical coverage, aren't we already saying that all the staff, the staff is going to they must meet clinical needs. So therefore, there would automatically be 24/7 clinical coverage.
Yeah, but I mean, like what that is, does that mean like, for example, is there a nurse on duty 24/7, but no doctor available till the morning? Or is there a doctor on call for the nurse to call, or does a doctor have to be on site? Those are the things I don't know how it should be. And I'd like to hear in the feasibility study, like to do this right, here's the right staffing mix. I'm guessing from experience, it's a doctor has to always be there has to be a medical person on call at all times, and that you can have other kinds of care staff that have other kinds of training. Like my guess is there's going to have to be a nursing person on duty, but probably not a social worker overnight or something like that. I don't know.
I'm sorry, but we have Katie for 10
Yeah.
more minutes and we still have a few sections to go. So hold your questions.
Okay, so where we are right now is I hear that you're interested in possibly removing B6 from the list and instead in the feasibility plan, ask the administration to address the types of professionals to form a multidisciplinary team for the forensic facility based on best practices and to supply some staffing strategies for the forensic facility.
Staffing strategies.
Yeah.
Well, you're good.
Subdivision, section 7, separation from correctional.
Before you go ahead, can you leave in the thing? Oh, okay.
Section 7 is the co-location with sentence and general correctional populations. I think that's covered in the draft now. No use of correctional uniform segregation or disciplinary sanctions. I could put that into section 4B.
I got a quick question.
Yeah. Go ahead, Ellen.
Okay, no use of correctional uniform segregation, disciplinary sanction. There might be some situation where you've got to call in corrections or policeman or something. To put that down, I think you're opening up a can of worms, but, and another situation, if a person is pretty much competent to stand trial, somebody's gonna transfer that person to the court system. Probably gonna be a uniformed officer. So it's something to consider.
Yeah, and also if we say no use of correctional uniforms or segregation or disciplinary sanctions, are we essentially banning seclusion and restraint from this facility?
Well, segregation.
Segregation would be.
Yeah.
Does that seem wise?
Can we discuss that after we get through all of these?
Okay.
Thanks.
I will flag it in my thing.
I passed off my list for now. Ensure safety through therapeutic design and clinical supervision. maybe that is sort of part of the instructions on the feasibility plan. Eight is the court review and time limits. So require regular court review of competency status and progress. So it sounds like you've had conversations and testimony about the right time frame. So I think, there's already regular reviews built into the work that the House Judiciary is doing. I don't know if that is the time frame that this committee would recommend, but I will flag that, that if 6 months, I think it's 6 months in the bill. If that is not the policy decision that this committee makes, I could flag that for the other committee. The second bullet is establish limits to prevent indefinite detention. Right now, there are some off-ramps out of the forensic facility and the work that House Judiciary is doing. I think you'd have to review that to see if they're sufficient for you, but that concept is being discussed downstairs. Require timely discharge of transition to appropriate level of care when restoration is achieved or unlikely. So we talked a little bit about keeping somebody whose competency has been restored in a forensic facility throughout their pending trial and trial. And we talked a little bit about discharge and transition and what that outpatient system might look like and what you want to hear back. So maybe we'll just pause on that. Let's see. Subdivision 9, independent quality oversight. Require public reporting to legislative committees and various data. The recommendation I'm making here, so in the bill that came over from the Senate, it does have an annual report. House Corrections and Institutions wants to take it out. Thinking that sort of it's putting the cart before the horse in that we don't know what this forensic facility totally looks like until we have a feasibility plan and the legislature decides on a course of action. So maybe at that point in time is when you require a annual report. But at this point, you could ask for data reporting metrics as part of the feasibility plan. Does that work? Yes. Okay.
Yes.
Reporting.
Can I also ask the public reporting does this public report include that data that's in bullet number 2 of number 9? Because aren't we getting into confidentiality in some of this?
Let's see, length of stay, outcomes,
About safety incidents?
safety incidents.
I mean,
Unless you report all this right now,
is it public?
it's in DMH.
Yeah, provided there's no names.
Yeah.
Well, I know, but if we have a forensic facility with like 4 people,
There's one person in there.
then
So let's not put this in statute. Let's recommend it for the study.
Okay.
That they look at what data to report. That's what Katie and I discussed.
Okay,
10 is implementation and rulemaking. Again, Corrections and Institutions is recommending taking out the rulemaking section from the bill, thinking that it is too premature, and instead waiting till the forensic facility comes back, having a better sense of what it will be, and then putting rules in place. Okay, that's it. You made it through.
made it through.
I saved my comments for the end.
Thank you. Go ahead.
Okay, so
Thank you, Katie.
I might have missed this, and that's why I was trying to check with you, but then we decided to keep moving. But when you were in section 6, did you say anything about including language about the training of staff, like what they would recommend the training and approaches towards? Because I would like it in there, if they're going to give a feasibility plan or study, for it to include their recommendations on approaches to trauma-informed care, de-escalation training. Like, in other words, not just saying the words, but being like, here's examples of systems or programs or philosophies or trainings that we would implement in, like, to build a culture in the facility of recovery. You know, like, I believe our like staff are capable of this. I just would like to see it, you know, to see it articulated versus just having like saying people are going to be trained in this thing. It's like, well, what, if it's a feasibility study, what is the proposed approach, you know? The other thing was, back to, Penny, you mentioning the correctional uniforms and security. Maybe there's language, and maybe you already wrote this, and I'm repeating it, but I didn't have a chance to check with you, so now I'm checking like that. Maybe it's like, from the clinical perspective, what is the approach to security? You know, and how does that intersect with correctional facilities? Because it could be that the plan includes a variety of paraprofessionals who serve in a security role in the facility, and that if a person has to leave, they hand them off to someone, you know, similar to how like in a correctional facility now, they bring them to the Sally Port or whatever they call it. I think that's actually what they call it. And then people like me or the EMTs will meet them in that area, and there's a transition between providers there, you know, or they go, you know, instead of the ambulance, maybe they go with a sheriff or something. But what I'm getting at is there would be like it'd probably be an intake or a admissions or discharge area. That could be where this, so what I'm getting at is I'm not trying to control what it is. I'd like to hear what the best practices would be for security. And that would address that issue of the uniforms, because instead of us just banning it outright, we asked them for the recommendations.
Excellent.
Okay, yeah, you're right, but we're talking about their patient safety. We're talking about the public safety. What about the public and the staff? I think most of these places, don't they have security people on the premises?
Yeah.
So you're saying they shouldn't be wearing a uniform?
No, I'm saying we should ask DMH or whoever does the study what they think is the best practice for running security there. If they say uniform, then or, you know, they say it, but they say no uniform, but they wear hospital gear, you know what I mean? But like asking them how to navigate that versus us just banning it outright.
But I don't want to forget the staff safety at all costs.
I don't either. And I just want to make one thing clear with regard to public safety. This obviously is a lot about public safety, but in order to contain the discussion, the stuff in here doesn't speak specifically to public safety. My background is in behavioral health and mental health. And so the recommendations I lifted up are related to that. And I know that there's a lot of solid work being done in the other committees regarding public safety recommendations. I'm going to suggest that a way forward, Katie, I know it's after too, but a way forward might be for me to take this document, and I've noted where Katie recommended things could go in a study, or where there were significant questions from committee members that needed further discussion. So I would take this document, reorganize it into sections that I propose we put into the bill language now, 4B, Katie referenced, and then the rest I would put into a section that just says possible study. Does that make sense, Katie?
It feels like an extra step to me. If you want to do that, that's fine. I mean, it doesn't affect my time, but I think at this point, we're just working on a compressed time frame. I'm thinking it makes sense to ask Representative Emmons if she is ready to integrate your recommendations into hers, and then I just go and do it.
I just want the committee to be clear on what our recommendations
Oh, I
are.
see. I was thinking I could just highlight them in a different color, so it would be like.
If you want to do it, then I don't have to. That's great.
Okay, but I haven't been able, I did reach out to Representative Emmons.
Great.
And I have not heard back, so I am sort of waiting on that.
And I had a 3-second passage in the hallway with Representative Emmons, and she indicated she'd like these recommendations by Thursday at the latest. So that's the timeframe we're working in.
So I feel like maybe there needs to be, well, I need more guidance, I guess is what it comes down to, because I'm walking through new language with human services and corrections and institutions tomorrow. I had thought maybe I would just include this language as part of it to keep us moving, but you wouldn't have a chance to sort of weigh in and look at what I've put together. So I don't know how you want to proceed that way. Should I hold on to that language and keep it separate and apart from what corrections and institutions doing.
Is there a time that we can meet before, can we coordinate a time to meet before you meet with them? I know that your schedule is so tight to include right this minute.
Could you do what you said and highlight that language so we could review it before, and if we had a minute with you, we could at least.
Yeah, let's see, I'm booked from 9 to 12 and I'm booked for most of lunch. You're on the floor at 1. If you got off the floor at 2, then maybe, I don't know how realistic that would be.
Tomorrow? Yeah. What's the notice tomorrow? I have a that's stuck in that. That's
All
really.
right, well, we'll coordinate a time.
Thank you so much, Katie.
Yeah. There's a lot of good stuff. And
It's a 325. No, Colchester.
Oh, good. Yes, sir.
Actually, one of my.
You ready to move on? Okay, so S-190. We don't have Jen yet. Jen will be here soon. So if you recall, I mean, S-190 is this bill that we've had on the wall, and we kept it on the wall because there have been lots of people doing lots of things, and trying to get us good information before I introduced it to the committee, because I didn't want to confuse everybody, frankly. So, and I just want to let you know, I actually have been working with Jen on some language, which I'm going to put forward to the committee for consideration. But I wanted to get some testimony prior to that, from Green Mountain Care Board and DFR, and particularly around, you know, some of the decision making, like the bill that came over from the Senate has a cap on the QHP market. And we deal with, and then we've heard proposals from financial regulation about possibly like changing and putting caps on some other services for the whole market. And it dawned on me when we had the broker in the other day that we in this committee have, because we don't have much control, or any, almost, the ERISA market, I thought we should learn about the self-funded market a little bit. So I've asked both the board and DFR to come in and talk about that, as well as some proposed language for 190. So first up, we have Emily Brown. What was that for a precursor?
That was good.
I know, that was.
I'll save my questions now for the right person. You said, you framed it.
Now you guys save your question.
It was different.
Good afternoon. My name is Emily Brown. I'm the Executive Director at the Green Mountain Care Board. So here to talk about S-190, and as the chair said, why we've chosen to identify the QHP market for this interim statutory cap, but then also putting it in the context of the rest of the commercial market. I think this committee heard a lot of testimony last week about wanting to spread the benefit of reference-based pricing to the whole commercial market and not wanting to, single out the QHP market. So I'm really here to talk about and respond to those points. So I think I'll start by level setting and saying the board last year was and is required to implement reference-based pricing. We are currently and have identified a contractor who's going to start working with us to develop a reference-based pricing plan, which will impact all commercial payers in Vermont. So I just wanted to start by saying that we are not saying we are only doing reference-based pricing for QHP and no one else is going to get the benefit. We are taking a system-wide approach to reference-based pricing. We are already starting on that work, and that work, when implemented, largely through and connected to our hospital budget process, because remember, reference-based pricing as identified last year, and what the board's been asked to do is to do it from the hospital side. So we will be setting hospital prices and identifying hospital prices and lowering the prices on that side. And that way, all those savings are going to flow through to all commercial payers. In S190, we have identified the QHP market as a market that needs immediate help to provide stabilization and to make sure that market stays available and accessible to all those who are now in it and all those who might have actually left the market, and providing them maybe an option to re-enter that market. So just to level set, S190 was that created the interim statutory cap of 250% of Medicare. And as I said, over the last year, that market has seen significant declines in enrollment. I think this year alone, we've seen more than 5,000 individuals leave the individual QHP market. That's almost a 20% decline. That was largely attributed to the fact that the subsidies went away before, when there were the enhanced subsidies. About over 90% of that market was receiving subsidies. I think that number is now at about 77%. So you have a large part of that market now that are not benefiting from any subsidy. And in reaction to that, many people and families are leaving that market. There are further actions that are coming down from the federal government that we expect will create further disturbance in the QHP market. One of those is a change to the federal administration's approach to silver loading. I won't get into the details of silver loading, but essentially it was a step that the board took to make up for the lack of CSR payments that the federal government decided not to pay.
Hold on one
sorry.
second. Tasha,
Freeze.
are we okay?
Whoa. It hasn't done that before in here.
Hold on one second, we might,
Okay.
We might not be.
CSR.
Cause
meeting's being like.
cost share
We have to
reduction.
pause because the live stream is disrupted.
Sorry.
We can't talk about policy.
Okay.
It's an acronym.
We can only talk about other random things.
It's just an acronym.
Want me to start a lot live and then starting up again?
Yeah. I looked up and I'm like, well, that's weird. Why am I looking down if I'm
Weird.
looking and staring at?